This is a real pleasure to be invited to this annual Saudi Hematology Congress meeting. And I would like to present for you today some of our research into mechanisms of resistance to BCL2 inhibition. These are my disclosures. And I would like to start with the mechanistic schema, how BCL2 inhibitors work. Let me get a laser pointer. So it's based on the dimerization between and interactions between anti-apoptotic BCL2 family members, such as BCL2, that control mitochondrial integrity, and pro-apoptotic family members, most commonly as BEM or BAX. So in the tumor cells, there's a high expression of BCL2, and the tumor cells are thought to be primed, which means that they are pre-bound with these pro-apoptotic family members. And if you have a drug such as BCL2 inhibitor known as venetoclax, it binds BCL2 and results in the release of these pro-apoptotic family members that induce cell death. However, if there's a clone that overexpresses a BCL-XL, MCL1, or other anti-apoptotic family member, or if there's some epigenetic upregulation of this proteins, then despite the fact that the drug is still bound to the BCL2, there's a relocalization of BAX and BIM to these other family members, and as a result, there's no cell death, there's a resistance. So, of course, these are the results of the randomized azacitidine venetoclax trial that were presented at ASH last year, long-term follow-up. And unfortunately, what we realized that this therapy, despite being really powerful and revolutionary in older unfit for chemotherapy AML, it's not really curative because, as you can see, there's still a significant difference between azacitidine and the combination. However, patients continue to relapse long-term, and the cure appears to be less than 20%, which indicates rapid development of resistance. So we put together this slide that I will go through in a few minutes that displays most commonly recognized mechanisms of how that happens, and it's occurring on multiple levels. So as I mentioned, the most common mechanism of resistance is because of the overexpression of other family members. Now, how that happens, this could be driven by what we call signaling mutations, and I will give you examples of both FLT3-ITD and RAS mutations. There's also data that monocytic state can be associated with upregulation of specifically MCL1 and BCL2A1. And then there are other mechanisms of resistance. BAX is required for the induction of cell death, and the team at Australia found the mutations in the BAX. I will show you that slide in a moment. Then there's a deficiency of the BAX, whether it's on the protein level or RNA level. And this is most commonly caused by the mutations in the gene called TP53 that results in the deficiency of both BAX and BAC. And this is actually one of the most common mechanisms of resistance to cell death. In addition, there are data that mitochondrial structure plays a role, and I will present it to you in a second. So these are the mechanisms of resistance that I will show you in the next few slides of my talk. So again, starting with the BAX resistance, this was presented and reported in Blood 2020 by the team of Andrew Way and his colleagues from Australia. I haven't seen the follow-up reports. However, what they showed is that the mutations in the BAX, most commonly in this P168A mutation, results in the inactivation of BAX, inability to go to the mitochondria and cause permeabilization of the membrane. They identified these BAX mutations in about 17% of patients who progressed on venetoclax-based therapies. And the location could be different, but most commonly in this BH3 binding domain. So at least this is something that we are not routinely looking for, but perhaps we should be looking and doing the sequencing to identify this BAX mutation and how they're associated with genetics, and all those questions remain unanswered. Going back to this mitochondria structure, so this is a work from Yannis Saifantis' group from NYU that was published in two cancer discovery papers in 2019, 2023. In the original paper, they generated the venetoclax resistant cells, and they showed that the mitochondria structure becomes much more tighter, as you can see here. And by protein analysis, they identified upregulation of the protein called ClipB, which is important for this structure. So what happens is the crystals are more narrow, and that results in the delay of the cytochrome C release and resistance. If you silence this protein through a guide RNA CRISPR approach, you can see that you can partially reverse the sensitivity to venetoclax. And then in most recent subsequent talk, a paper that just came out recently, they did the CRISPR screen and identified a number of the proteins that are involved in the process of what we call mitophagy. So this is depicted here, and is essentially when BHE mimetic work, there is a damage to the mitochondria. However, this damage can be repaired by removal of this damaged mitochondria and selection of the healthy mitochondria. And this process is called autophagy. So you end up with perhaps fewer mitochondria, but they have fitter structure and they can resist cell death. They identified several proteins that are involved in this process, and there's a research ongoing to knock out some of the, or silence, inhibit some of these proteins, such as MFN2. Going back to the previously identified more common mechanism of resistance, in the original study where we combined the data from low-dose venetoclax and Vidasa venetoclax study, we identified two mechanisms of resistance to venetoclax. So the first one were mutations in p53 associated with chromosomal aberrations, complex karyotype, deletion of 17p. And this is, as you can see, in patients who are relapsing or primary refractory. This is a majority of the patients presenting with these mutations or complex karyotype. The second is what we call signaling mutations that were identified in a smaller number of patients. And for example, FLT3-ITD by single-cell DNA sequencing, this mutation can go down. However, it gets selected and presents resistance to the venetoclax treatment. So of course, we first pointed out to these mutations, and this was confirmed in the recent analysis of the ALI-A study, again presented by Hartman-Doerner at ASH 2022, where he looked at the utility of ELN22 classification and found that it was not quite useful for predicting resistance to HMA venetoclax. However, he identified novel sort of patterns of resistance, and they were similar to what was reported before. So the worst case is a patient who has p53 mutation. You can see here survival is about 5 months. And then there's an intermediate cohort with patients who have either FLT3-ITD or RAS mutation, and these patients are doing also not well. And then there's a group that is doing better, and these are patients who have wild-type p53 and no signaling mutations. So FLT3-ITD, just to start with that, is a signaling mutations, as you know, one of the most common mutation in AML. And the reason why the cells are resistant is because downstream of FLT3-ITD is a multitude of signaling pathway, which eventually led to the stabilization of MCL1 through both transcriptional upregulation through STAT5 and also the protein stabilization due to reduced degradation of the protein. Fortunately, we now have approved FLT3 inhibitors, and since this is upstream, if you block FLT3 with some of these inhibitors, this is I think the AC220 or quizartinib, you get some downregulation of MCL1, but you're also getting upregulation of this protein called BEM. And if you recall from my initial schema, this is a pro-apoptotic protein which can in fact bind to MCL1 and inhibit its function. So if you use the BHA profiling assay, you can see that in the resistant cells with the treatment of different FLT3 inhibitors, there's a switch towards BCL2 dependency as shown here and higher sensitivity to venetoclax or ABT199. This is depicted here in the cell growth assays when the combination of quizartinib and venetoclax results in near complete elimination of cell growth. And this was seen also in vivo in this model of cell line, but also subsequently in PDX models that were conducted where venetoclax plus quizartinib inhibits the tumor growth. So this led to the combination of FLT3 tyrosine kinase inhibitors and venetoclax with the different TKIs such as gilteritinib and quizartinib. And in fact, this was seen in the clinical data. So the analysis of the VIALE-A study showed that while in general, patients who have FLT3 mutation, they are responding better to the combination of venasa compared to azacitidine alone. This is essentially limited to patients who have tyrosine kinase domain mutations. However, patients who have FLT3 ITD, they essentially have no benefit from this combination treatment. So going back to the new treatments, again, the introduction of combined venetoclax and gilteritinib in the relapse refractory setting resulted in the high response rate of about 80%. This is now published in JCO of this past year. Remarkably, that patients with prior TKI exposure were similarly sensitive as compared to all cohorts. And if you can get these patients towards stem cell transplantation, in fact, patients can enjoy long-term survival. However, there are some resistance mechanisms that were also described last year, and some of them are related to RAS mutations. However, in the majority of the patients, this combination led to the reduction of the FLT3 ITD VF in all 14 patients looked at. So since then, there is now what we call triplet therapy for all the patients unfit for the induction chemotherapy, which combines azacitidine, venetoclax, and gilteritinib. And this is a report from MD Anderson group at ASCO of 2023, where they showed very high response rate of 100% with this combination, high rates of proceeding towards allogeneic stem cell transplantation, and estimated 2-year survival of 71%, really unparalleled data compared to the historical control. However, this combination is quite myelosuppressive, so there is a reduction of the doses of both gilteritinib and venetoclax required, especially if you go long-term, to be able to keep patients on study. So another example of signaling mutations is upregulation of RAS-MAP kinase pathway. And this is work from our lab, where we generated venetoclax resistant cells and performed all kinds of analysis, genomic analysis, proteomic analysis. And one of the strongest pathway that was upregulated is MAP kinase pathway. We confirmed that on the protein level, as it's seen here. And as a consequence of this pathway, again, the MCL1 protein was upregulated in all the 3 resistant cells compared with the control cells. As you can imagine, if you treat cells with MCL1 inhibitor, the cells are actually sensitized to venetoclax and are being killed. The most common mechanism of upregulation MAP kinase pathway in AML is RAS mutations. And looking at the patients who progress on the study, we showed using the single-cell DNA sequencing, again, selection of this RAS mutation, KRAS, NRAS, and PTPN11 mutations in several patients we looked at. We also confirmed that there is upregulation of MCL1 in some patients, reduction of BCL2, as shown here in this exemplary patient. We then engineered AML cells to express inducible RAS mutation and show that the cells become resistant to venetoclax compared to control. But again, they remain sensitive to the MCL1 inhibitor and the combination with venetoclax. And this was seen also in the in vivo models of this cell line derived with NRAS G12D mutation, when only the combination reduced tumor burden and reduced the AML development. However, as we know, the MCL1 inhibitors are not currently approved yet for therapy, and they're associated with on-target troponin release, which prevented their further development. The studies are still ongoing. So finally, going back to the p53 mutation, as I mentioned, this is the most common mechanism of resistance to venetoclax. It's the same schema that I showed you previously. These are patients who have p53 mutations or complex karyotype, and they're selected by the treatment very quickly. So the Dr. Wei's group, using again single-cell DNA sequencing, showed that these mutations here in red, also this KRAS mutation, are being upregulated or rather selected by the venetoclax therapy, and this is sort of universal in all patients. He also showed in his plenary paper in Blood 2021 that if you use the combination of BCL2 and MCL1 inhibitors, you actually get enough release of pro-apoptotic family members such as BAX and BAC, and that results in the cytochrome C release and cell kill. So you can in fact overcome this by combination of these two BH3 mimetics, and this was later confirmed by the work by Michael Andreev's group, which similarly showed that in cells they have knockout of p53 or p53 mutation, combination of MCL1 inhibitor and venetoclax here in black results in synergistic efficacy, cytochrome C release, and the marked extension of the survival both in cell line model and also in PDX. But again, we don't have MCL1 inhibitors, so what else can we do? In our lab, we elected to look at the combination of venetoclax with immune therapy. In this case, this is inhibiting CD47 or don't eat me signal. So very quickly how this works. So the cancer cells express high levels of CD47, which prevents phagocytosis by the immune cells such as macrophages. So the antibody that was developed called magrolimab can inhibit the CD47 and results into the engulfment by the macrophages, which is shown here beautifully when the macrophages start to engulf green tumor cells. We decided to look at that, but because in the initial phase 1 study in p53 mutated AML, there was high response rate and a very respectable 6-month survival that was presented previously. So we went back to the lab and looked whether the combination of venetoclax, azacitidine, and magrolimab can actually work together. And we showed that in this model, this is not p53 mutated model, but just a model of signaling mutations AML. Both Venaza and magrolimab have some activity, but the combination was doubling survival. So this eventually translated into the clinical trial that was led, investigator-initiated trial by Dr. Naval Davar at MD Anderson, and they included both p53 mutated and wild-type patients, and they showed that even the p53 mutated patients had high CR/CRi rate and perhaps improved overall survival, which is shown here. Of course, the data were still inferior compared to the wild-type patients who are presented here in the top. So this is now ongoing as a phase 3 trial led by Gilead that randomizes the azaven and the magrolimab in the triple combination. But perhaps some of you are aware that at least in MDS, magrolimab recently failed to reach the endpoint, and the studies were placed on hold till further review. So finally, I wanted to talk to you in the last few minutes about cell state and how that may impact the resistance to venetoclax. And I would like to show you the example of this acute erythroid leukemia. So acute erythroid leukemia in WHO, it's obviously triggered by the proliferation of these erythroid cells, and they have very high frequency of p53 mutation, very poor survival of about 5 months. These patients are refractory to the chemotherapy, and unfortunately, they're also refractory to venetoclax. So the recent report from the group of University of Helsinki, where we collaborated with, has shown that these cells have, by the CRISPR screen, high dependency on BCL2L1, which is a gene encoding for the protein BCL-XL. Again, venetoclax does not target BCL-XL. This was confirmed here, and also by use of the BCL-XL inhibitors, which had a significant efficacy in this erythroid leukemia cell lines, also in megakaryocytic leukemia, AML. If you look at the gene expression data in different available gene sets, you can see that this former FIB category of M6, which is erythroid leukemia, or M7 megakaryocytic leukemia, they have very high levels of BCL-XL compared with any other AML. This is TCGA, this is HEMAP, the same with the M6 have high levels of expression, and this is St. Jude cohort, which show the same data. And they also show that using the tool inhibitors in this HEL cell lines, you can get single agent efficacy. However, the development of BCL-XL inhibitors has been also struggling because of thrombocytopenia, which is on-target toxicity of this type of drugs. So in our group, we have been looking at the efficacy of the products. So BCL-XL products, they're being degraded through, in this case, VHL-E3 ligase, and this is a structure of this complex molecule that binds BCL-XL. So the reason these products avoid thrombocytopenia is because VHL-E3 ligase is expressed in tumor cells, but is not expressed in platelets as shown here. And consequently, there is no thrombocytopenia if you use this product. So our recent data indicate that while this erythroleukemia and megakaryocytic leukemia, they're totally refractory to venetoclax here, shown here in green, they're quite sensitive to this BCL-XL product called DT2216, which is in clinical trial, and also to the new generation BCL2 BCL-XL product 753B. And this is a two-molecule navitoclax, which is again still in clinical trials, but it's not yet approved for therapy in AML. So I would like to end my talk by postulating that survival in AML is generally BCL2 dependent. However, there is a codependency on BCL-XL and MCL1, and that affects the resistance that can develop with the treatment. The resistance can be multifactorial and is most commonly associated with PFHC or signaling mutations and also the differentiation state. And this is downstream reflected through the deficit of activators such as BAX, which could be due to PFHC mutation or actual BAX mutations, and or switch to other anti-apoptotics such as MCL1 and BCL-XL, which is seen with the signaling mutations and differentiation state. We think that using the products, at least for BCL-XL therapy, is quite effective and avoids thrombocytopenia and can be used in certain ven-resistant subsets. And of course, we are still hoping that MCL1 inhibitors will be coming through in the clinical practice. We're also looking at the combination with immune therapies that I've shown you here, and the novel treatments that are being thought of are direct BAX activators or inhibitors of mitophagy that are being studied in preclinical space. So I'd like to thank you for listening and acknowledge my collaborators at MD Anderson, both in the lab and in the Department of Leukemia. I recently moved to the Montefiore Einstein Cancer Center in Bronx, and I would like to thank my collaborators here and multiple collaborators across the country and the globe, particularly Tony Letai, who has led the seminal discovery in BCL2 field and co-developed venetoclax with our team. Andrew Way in Melbourne, Australia, showed you a lot of data. We have collaboration with the St. Jude, with Charles Mulligan and Ilaria Kubuchev on the AEL, with Dr. Zhou, who developed the product. He's now at the University of San Antonio, with a team of Yanis Aifantes, and of course, industry partners and funding. So thank you for your attention. I'm happy to answer questions.